Hi everyone, my name is Med2Med. This video is going to be on the different types of leukemia. It's very easy to get mixed up with all the different terminology, so I'm hoping that this will clarify some of the things you might be confused about. These notes are based on the following resources. I've been using Scott's Notes recently, a PDF with concise notes with everything you need to know for medicine on the wards. As always, I've been using the Oxford Handbook of Clinical Medicine and utilising the NICE guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. So before we delve deep into the different types, let's simply start with, what is leukemia? Well, leukemia is a blood cancer. It's usually found in the bone marrow and causes abnormal white blood cells. Okay, so now we have an idea about what leukemia is, let's take a look at the white blood cell lineage. First, we have the main stem cell, responsible for specialising into each different cell. Then, the cells become either myeloid or lymphoid. If you already have some background knowledge on leukemia, you may recognise these terms. Myeloid or lymphoid leukemia come from either one of these common progenitor cells. Then you have all of the cells that develop from these common progenitor cells. So on the myeloid side, we have the key players like the neutrophils, the monocytes, the macrophages. On the lymphoid side, it's a lot simpler. There's T cells, B cells, and NK cells. When we talk about leukemias, we describe them in terms of being acute or chronic. This describes how mature the cells are. When we talk about acute leukemias, we are describing these early, less differentiated cells. When we talk about chronic leukemias, which are more further down on the diagram, these are the more differentiated cells and tends to progress over a longer period of time. As previously mentioned, you can also describe cancers according to what type of cells they are. If they are involving myeloid cancers, they would be on the left side. And if they are lymphoid cancers, they would affect the cells on the right. You may now realise that you can separate the cancers according to how differentiated they are and what type of cells they affect. You can see on the top left we have the chronic myeloid leukemias. In the top right, there's the chronic lymphocytic leukemias. You can see in the bottom left we have the acute myeloid leukemias, and again in the bottom right we have the acute lymphocytic leukemias. Let's look at acute lymphocytic leukemia first. It's important to note that you may come across it being named lymphoblastic, lymphocytic, or lymphoid. Don't worry, these are the same thing. So, acute lymphocytic leukemia, ALL. This is the most common childhood cancer and is rare in adults. We already know that this cancer affects mature cells of lymphoid lineage, the B or the T lymphocytes. More commonly, in 80% of all cases, it affects B lineage. We believe that it could be caused by a genetic susceptibility, such as a chromosome translocation, an environmental trigger like having Down syndrome or being exposed to radiation while in the womb. When we think about the symptoms of ALL, we need to establish that these occur due to bone marrow failure and infiltration of cells. So both causes of these symptoms present differently. So let's describe the symptoms associated with bone marrow failure first. First we have anemia, which is due to those low hemoglobin levels. Infection could occur, which is due to this poor white blood cell count. And bleeding, due to thrombocytopenia. The reduction in all of these cells is due to the bone marrow producing fewer cells, other than the cancerous lymphoid cells. Now we have the other group of symptoms, which is where the cancer can infiltrate other organs, such as the liver, causing hepatomegaly, the spleen in splenomegaly, the lymph nodes in lymphadenopathy, the testicles in orchidomegaly, and the central nervous system, which creates cranial nerve palsies and meningism. Personally, the way I like to learn is I like to picture a typical patient in my head who may have this cancer, so I can incorporate all of the symptoms into one image. So for me, what works is thinking of a tired child, remember it's predominantly affecting children, with giant organs bleeding heavily due to the thrombocytopenia after getting an infection. You're going to do some tests for this patient if you're concerned that it could be ALL. First, blood films will show characteristic blast cells, as well as in the bone marrow. The white blood cell count is usually high as well. Then you could do a chest x-ray and a CT to look for both the mediastinal and abdominal lymphadenopathy. Lastly, if you're concerned about CNS involvement, you do a lumbar puncture. Right, so our patient has presented with key symptoms of ALL. We've done some tests and we've identified that they do in fact have this disease. So how do we treat it? I like to use any random mnemonic of SCIB. So for instance, selfish individuals can't borrow. So of course this stands for supportive, infections, chemotherapy and bone marrow. And it's all the things you want to think about and consider when treating patients with ALL. So firstly, we have supportive measures. You consider giving blood products or platelets, transfusions. You give allopurinol to prevent tumour lysis syndrome. And you may insert a Hickman line for IV access. Next, infections. These are incredibly dangerous in patients with cancer due to low neutrophil levels. So you should give immediate IV antibiotics. You may also give antifungals, antivirals, and you need to treat this neutropenia if present. Cancer chemotherapy is complex. You need to give drugs to induce remission. Then you need to give high to medium dose therapy and blocks over several weeks. You then give the CNS prophylaxis, for instance methotrexate. And then you finally give maintenance therapy, so that is prolonged chemotherapy. Lastly, you may be able to consider a bone marrow transplant, which is the best option for younger adults. We mentioned that allopurinol was given to prevent tumour lysis syndrome. This is where, when a tumour cell dies, as it does, it releases all of its contents into the bloodstream and causes severely deranged blood results, and allopurinol can prevent this. Okay, we're finished with ALL. Let's move on to acute myeloid leukemia, which, like ALL, is an acute process, so there's less differentiated cells, but this time it's involving the myeloid cells. This is the neoplastic proliferation of blast cells. So, AML is the most common leukemia found in adults, particularly around 60 to 70 years of age. It can occur post-chemotherapy, for instance, in lymphoma treatment. Whilst this leukemia is similar to ALL, in that it is associated with radiation and Downs, there's also an association with myelodysplastic syndromes, a milder form of blood cancers which can develop into full-blown leukemia over time. Again, just like in ALL, symptoms are related to marrow failure and infiltration. You may find anemia, infection, or bleeding, but you may also find something called DIC in a specific subtype, disseminated intravascular coagulation. You can see this in the top right. This is a condition where blood clots form throughout the body in the small vessels. Relating to infiltration, of course, you may notice the typical hepato or splenomegaly, but also potentially gum hypertrophy and bleeding that you can see down in the bottom right, as well as skin involvement. In AML, CNS involvement where patients present is rare. When attempting to diagnose AML, don't be thrown off by the white blood cell count. Yes, it can be raised, but it might also be normal or even low, because these abnormal blast cells might not be present in large quantities in the peripheral blood, so biopsy is necessary. Biopsy is the only way to differentiate between AML and ALL, due to the presence of something called Auer rods. Again, treatment of AML is very similar to that of ALL. The supportive care and infection treatment is exactly the same, but the chemotherapy is more intense and can result in long periods of bone marrow suppression, which in turn leads to neutropenia and thrombocytopenia. Again, a bone marrow transplant can be carried out as either allogenic, if prognosis is poor, so that's from HLA-matched donors, or autologous, which is faster recovery and has a lower morbidity risk.